Welcome to our video about open angle glaucoma. This is the most common type of glaucoma, and in this video we will review a bit of anatomy, specifically the aqueous humor pathway, and then discuss the epidemiology and pathophysiology of primary open angle glaucoma. We'll then conclude with the clinical presentation and diagnosis of the disorder. Note that in this video we will not be reviewing therapeutic strategies for open angle glaucoma. Those will be covered in our separate video on open angle glaucoma treatment. So first, we should talk about what we mean by open angle. So the angle refers to the angle between the corneal endothelium and the superficial surface of the iris. This is also known as the iridocorneal angle. Open angle glaucoma is sometimes referred to as chronic glaucoma, as symptoms slowly develop over time. Closed angle glaucoma, on the other hand, sometimes referred to as acute angle or angle closure glaucoma, occurs when this iridocorneal angle becomes closed, often in the context of pupillary block. As you can see here, aqueous humor cannot enter the aqueous chamber to be drained by the trabecular meshwork, and this can cause pressures in the eye to rise rapidly. We'll talk about closed angle glaucoma, which is an ophthalmic emergency, in a separate video. So let's quickly review the pathway by which aqueous humor is formed and then drained in the eye. So aqueous humor is first made in the posterior chamber by the ciliary bodies. This aqueous humor then flows through the pupil into the anterior chamber and then is drained by this trabecular meshwork and into the canal of Schlemm. Chronic or open angle glaucoma can occur when this trabecular meshwork gets clogged, and this can prevent the adequate drainage of the aqueous humor, causing the intraocular pressures to increase, which can damage the optic nerve. Note that this is a bit of a simplified representation of glaucoma, and I'll talk about this more in the next few slides. So why is glaucoma so important? Well, it is a leading cause of blindness. In the United States, glaucoma affects over 3 million patients and accounts for more than 10 million visits to physicians each year. And this cost the U.S. more than $1.5 billion in healthcare expenditures. An estimated 120,000 patients go blind from glaucoma in the United States, accounting for about 10% of all cases of blindness. It is the second leading cause of blindness in the world, behind cataracts, with over 60 million patients affected worldwide. Note that these are statistics for glaucoma as a whole, but open angle glaucoma is by far the most common type, accounting for between 70 and 90% of all cases of glaucoma. So let's review the anatomy of the optic disc. So the optic disc is also known as the optic nerve head, and it's the point of exit for ganglion cell axons leaving the eye, and it's also what forms our blind spot. The optic cup is a white cup-like area in the center of the optic disc that contains no nerve fibers. The nerve fibers actually run between the border of the cup and the disc, and that's known as the neuroretinal rim. In a healthy eye, the optic cup is actually quite small compared to the optic disc. The normal range for this cup-to-disc ratio can vary, but a commonly used cutoff is about 0.4, where values above this increase the likelihood and suspicion for glaucoma. On the right is a cross-section of the optic nerve, and we can see this optic cup surrounded by the optic disc. In glaucoma, the optic disc is very large, often characterized by a cup-to-disc ratio greater than 0.7. On the right, we can see the significant cupping that is also associated with this thinning of the retinal nerve fiber layer. Now, it's important to note here that while increased IOPs or intraocular pressures is a significant risk factor for glaucoma, it is not a prerequisite for diagnosis. Some patients can have glaucomatous optic neuropathy without elevated IOPs, and some individuals with high IOPs can live their entire lives without developing optic neuropathy. The key is that glaucoma is a disease of the optic nerve, not of intraocular pressure. So here are some examples of actual fundus photos, one normal on the left and two with differing degrees of glaucomatous cupping. So on the left is a normal optic disc. It's pink and well perfused with a cup-to-disc ratio of about 0.3. The middle photo shows a moderate case of glaucoma where the cup-to-disc ratio is about 0.7. And on the right, you can see that this cup has expanded almost entirely to the disc margin with a cup-to-disc ratio of 0.99, indicating very severe glaucoma. So there are many risk factors for glaucoma. So age, race, family history are all risk factors that we cannot control. As we get older, our risk for glaucoma increases, and for reasons that are not entirely understood, African Americans are about 3 to 4 times more likely to get glaucoma than Caucasians, and they're also about 15 times more likely than Caucasians to become blind from glaucoma. Diabetes, hypertension, and hyperlipidemia are all comorbidities that also increase the risk of glaucoma. And then finally, one risk factor that we can monitor and control closely is intraocular pressure. And on the right, I'm showing a picture of a Goldmann applanation tonometer, which is the gold standard for measuring intraocular pressure. It's often seen attached to slit lamps and has this tiny flat curved-tipped cone that works by measuring the amount of force needed to flatten a part of the cornea. Often in the office, we'll use a tonal pen, which is portable and often much more convenient, and it works in a similar way, though it can be a little bit less accurate. So here are some examples of the varying visual defects that glaucoma patients might report. So some patients experience a black tunnel and others black patches. Some patients can experience a blurred tunnel, others can experience blurred patches. And other patients will report much more subtle findings, such as missing parts. So here we have this window that's missing. A very common presentation, however, is no visual loss, which brings us to our next key point, which is that chronic glaucoma can be asymptomatic. And this is because visual loss occurs peripherally rather than centrally, and occurs so slowly that glaucoma is sometimes called the sneaky thief of sight. Often this is diagnosed incidentally during a comprehensive eye exam, which might show elevated IOPs, optic disc changes such as cupping, and a repeatable pattern of visual field loss. Note that unlike closed angle glaucoma, open angle glaucoma does not present with pain or redness, and often visual acuity is spared because glaucoma tends to affect the peripheral vision rather than central vision. There is some controversy regarding the need or cost effectiveness of screening for glaucoma. There's really no robust evidence for or against screening. However, given the risk of blindness with untreated glaucoma and the effectiveness of treatment, certain individuals suggest that patients over the age of 40 undergo more regular eye evaluations. So how is glaucoma diagnosed? Well, it's diagnosed when there is characteristic optic nerve damage that is evident on fundus exam and or visual field testing. Note that increased intraocular pressure is not required to make the diagnosis. So diagnostic criteria for primary open angle glaucoma include optic nerve damage, normal or open anterior chamber angles, and no secondary causes of open angle glaucoma. These include things like pigment dispersion syndrome or pseudoexfoliation syndrome, which I'll talk about in a separate video. Visual field testing for glaucoma often shows peripheral vision loss, with central vision being affected only at very late or severe stages. So here we're seeing visual fields for the left eye. This is nasal, this is temporal, and here's the blind spot. And one of the first visual abnormalities that can be seen in glaucomatous damage is a nasal step, which affects the inferonasal visual field. And as glaucoma progresses, this nasal step can expand superiorly and temporally, eventually involving the central vision and causing irreversible visual loss.